Thank you, Dr. Stiff, for the very nice introduction, and I thank the Leukemia Research Foundation for giving me another chance to talk to you. So over the next 15 to 20 minutes, I'm going to talk about chronic lymphocytic leukemia, or CLL. And most of my talk, I'm going to emphasize some of the new treatment options that has been recently become practice changing, particularly in the last 1 year. And I'll emphasize that, but the first 3 or 4 slides, I'll talk about chronic lymphocytic leukemia, what we know now about the disease, and what are the prognostic factors, and then we will talk about the treatment options. Okay, so as an introduction, CLL is the most common adult leukemia because of the indolent nature. Many patients live for a long time, as you can see here. In 2019, we expect about 20,000 patients to be diagnosed with CLL. This is the data from National Cancer Institute. And the good news is majority of them, 85% or more, are alive after 5 years. And if you look at the deaths that occur over years, or rather over decades, from 92 onwards we have data indicating that the death rate in the United States for CLL has been steadily coming down. And this is till 2016. As you know, in the last 4 or 5 years, there have been dramatic changes in the way we know about the disease as well as treat the disease. So this curve is even more likely to be dropping. Already we don't have data beyond 2016 at this time. Now, CLL is a disease where you can diagnose and get most of the information you need about the disease from the blood alone, because CLL is a disease where the leukemia cells are there in the blood, so you can study everything in the blood. If you look under the microscope, a blood smear of a patient with CLL, this is what you see. And these small cells here are the lymphocytes, which are the leukemia cells. Now, the normal lymphocytes may look like that. That's the reason why we do some special studies in order to find out if these are leukemia cells or normal cells. And that test is called flow cytometry, which will identify the proteins on the surface of the cells, which can tell us if it is normal lymphocyte or leukemia lymphocyte. Then we do a variety of studies to find out what are the molecular abnormalities, because that's going to tell us the prognosis and also help us in identifying the appropriate treatment option. So what are the prognostic factors we know in CLL? Over the years, we have developed a lot of information indicating newer prognostic factors. As you can see here, there's a variety of them. Just an example, this CD38 is a protein on the surface of the leukemia cell. If it is low, those patients do much better than patients who have high CD38. Here is a mutation, IGHV. Patients who have that mutation do better than patients who don't have the mutation, which, as you know, is unusual because most of the time mutations are associated with adverse prognosis. So the point is, actually the entire point of this slide is that, when you look at the reports, many of you look at the reports now, printed reports or in the computer, you may see these terms: chromosome study, FISH study, PCR, mutation analysis, NGS or next generation sequencing. These are all tests we use now in order to find out more details about the leukemia cells. Again, these will help us in not only predicting prognosis to a fair extent, but also in avoiding certain medications or preferring certain medications based on these abnormalities. And I will touch upon some of them in the next few slides. Just as an example, how does chromosome or mutations influence the disease progression? So this is the way, this is a time factor here, and the patients who are being treated. If you look at this green dotted line, those are patients with CLL who have this abnormality called 17p deletion, which is the abnormality, the worst abnormality that you can get in CLL, the 17p, because that's associated with significantly adverse prognosis, even though the new medications have really changed the way we treat these patients. But you can see that patients who have this abnormality progress very rapidly compared to patients who have, for example, a 13q. Their progression rate is very slow. So chromosomes determine prognosis to some extent. And these abnormalities also help us in identifying the appropriate treatment. Another example is the mutation I just mentioned, that is the variable chain mutation, where patients who have the mutation, they do much better, even if they have higher stages compared to patients who do not have the mutation. So having said that, we all know that all patients with a diagnosis of CLL doesn't need treatment right away. In fact, most of the patients with CLL are watched for some time. And that applies to many of the blood cancers you heard here. And you will be hearing too, lymphoma, for example, low-grade lymphoma. Dr. Klein will be talking about it. Many a time you watch the patient, and unless and until there is a reason to treat, we hold treatment. So the main message here is observation is appropriate in the absence of indication for treatment. I emphasize that because that's one of the common questions the patients will ask. You diagnose me with a cancer and tell me that nothing need to be done. Does it make sense? Which is a very appropriate question to ask in the beginning. So that takes us to some of the newer treatment options. And if you look at the last 5-6 years, many new treatment options have shown up. FDA has approved many of these, starting with, for example, monoclonal antibodies. Most of you who are interested in lymphoma, CLL, you are familiar with the drug rituximab or Rituxan, which is a monoclonal antibody targeting the protein called CD20 on the leukemia cell or lymphoma cell. And now there are newer rituximab targeting at the same protein, but have much better effectiveness or side effect profile. One is this drug called obinutuzumab, known as Gazyva, or ofatumumab or Zera. These are two monoclonal antibodies which are second, third generation CD20 antibodies. Then there's a whole set of orally active medication. We call it BTK inhibitor, depending on the pathway that is inhibited by the drug. Ibrutinib is the first one. There's also acalabrutinib, which is FDA approved, but not yet for CLL. Idelalisib is another targeted therapy. It again inhibits a very specific pathway in the leukemia lymphoma cell called PI3 kinase. And there's a variety of PI3 kinase inhibitors now. And most recently approved is duvelisib, which also is very active and orally administered. Then there is a group of drug, so-called inhibitors of the protein called BCL2, which was, Dr. Hagen mentioned that along with this myeloma talk. Venetoclax is the classical example of that group of drug. It inhibits the protein called BCL2, which lowers the apoptosis, that way releases the apoptosis or killing of the programmed killing of the cancer cells to proceed. And I will show you the data indicating that venetoclax is becoming one of the most important drugs in CLL now. CAR T and transplant, I'm not covering. Dr. Stiff is going to talk about CAR T in detail, and you heard from Dr. Burns about transplant. So subsequent talk will be on first-line treatment and subsequent treatment. So what are the first-line treatment in patients with CLL who needs treatment? Chemotherapy has been historically the standard of care. Newer treatment options include monoclonal antibodies, which I just mentioned. And then you can combine these two. The combinations which are historically used is FCR, combination of fludarabine, cyclophosphamide, and rituximab, or BR, bendamustine and rituximab. Those who have CLL or interested in CLL and leukemia, you are familiar with the drugs I just mentioned. Ibrutinib is the novel agent. I'll talk about it. And venetoclax I just mentioned. These are newer agents, again, very active in CLL. So, as I mentioned, the role of chemotherapy is coming down because of all these new non-chemotherapy agents, just as in other blood cancers you have heard and you're going to hear. But in CLL, chemotherapy is still appropriate in certain patients. I just want to show you an example. If a patient is fit, previously you heard the term fit and unfit, which means patient can tolerate standard induction chemotherapy. In those patients, if they have the mutation I mentioned before, the IGVH mutation, if you give 6 cycles of the chemotherapy FCR, you can see here after 10 to 15 years, majority of them do not have evidence of disease after 6 cycles of treatment. Can we call it cure? I would, but because the nature of the disease, many of us are not still calling it cure. But if you don't have any evidence of disease after 6 cycles of treatment, 10 to 15 years later, I would assume that many of those patients are cured. So that is one subset of patients in whom chemotherapy still appears to be very effective compared to the novel agents. So let's talk about the novel agents. Well, it's a complicated picture, but I just want to show you that many of these new agents work by targeting either a protein on the surface of the cancer cell or a pathway which the cancer cell is depending on to survive. So here, this is the cancer cell, okay, and this is the protein, for example, on the surface of the cancer cell, which is called CD20, which I mentioned is the target for rituximab, which is also the target for the newer rituximab, obinutuzumab, or the GA101, which is the earlier name of obinutuzumab and ofatumumab. And now obinutuzumab is not yet FDA approved. We have very active clinical trials, which is even a newer third generation monoclonal antibody targeting the same protein. This is another protein on the surface of a CLL cell, CD52. Alemtuzumab is a monoclonal antibody called Campath. It was approved by FDA in the 2000s. It is less and less used now because of the more effective and less other antibodies with less side effects. BCR is the B cell receptor, which, as you can see downstream, there are many pathways. It depends, like the BTK pathway, which is inhibited by ibrutinib. PI3 kinase pathway is inhibited by these variety of drugs, many of them I just mentioned in the earlier slide. CD19 is the target for many treatments, including CAR-T. And lenalidomide is a drug you heard a lot in the morning in the myeloma talk, where it is FDA approved. In CLL, it's not approved, but as with many other blood cancers, this drug is very effective. So in the next 3 slides, I will focus on 3 major studies that were published or presented in the last 12 months as first-line treatment of CLL. And they really are very important and practice-changing. So the first one is combining the drug obinutuzumab, which is the newer rituximab, with the BTK inhibitor ibrutinib. And they compared it to the same antibody that is combined with chlorambucil, which you know is one of the oldest drugs for CLL treatment. And what did they see? That the patients who received ibrutinib along with the antibody did significantly better than patients who received the same antibody with chlorambucil. This is the line for them. Okay. Even if you take the patients with high risk, like the chromosome abnormalities or unmuted, which we talked about, even in that population, the combination of ibrutinib with this antibody did significantly better. Benefit was significantly better than patients who took the same antibody and chlorambucil. And this study led to the approval by FDA, the first non-chemotherapy combination, and this happened in January of this year. The second study I want to find out is comparing patients who received FCR chemotherapy, which I told you has been used as the standard of care for a long time, still in subset of patients, which is probably the most active chemoimmunotherapy we know. And that was compared to ibrutinib along with rituximab. And again, what does it show? Patients who received ibrutinib and rituximab did much better compared to patients who received FCR chemotherapy in terms of the time they remained without progression and the time they were alive. So in other words, ibrutinib and rituximab combination led to better disease control as well as survival compared to patients who received FCR. So that was the second study. Okay. And the third one was in patients who are older. In older patients, FCR is not a regimen that is very well tolerated, so the more commonly we use this regimen, that is bendamustine with rituximab. So this study compared bendamustine rituximab combination with ibrutinib rituximab combination. Again, what was the outcome? In this study, ibrutinib was given alone to some patients, and ibrutinib rituximab combination was given to another subset of patients. Both these patients, group of patients who received ibrutinib, did significantly better, as you can see here, compared to patients who received the chemo-immunotherapy combination. Again, showing that the novel agents, the non-chemotherapy combinations seems to be doing better compared to the standard chemoimmunotherapy. So the message here is that combination of ibrutinib, whether it is combined with rituximab or alone, leads to better disease control compared to standard chemoimmunotherapy in this patient population. So those are the three major studies which has influenced the way we practice CLL and the way recommendations are made for CLL treatment. What about the patient who relapsed? Chemotherapy is still an option, especially if they have induced chemotherapy in the front line. Monoclonal antibodies like ofatumumab, alemtuzumab, they are approved treatment for patients with the relapsed CLL. Ibrutinib is also approved for that, but venetoclax certainly is the drug that has been specifically approved for relapsed patients. Venetoclax, if you give alone, the response rate are very good, as you can see here. And many of these patients are in complete remission. Unlike ibrutinib, if you give it alone, many of them are in partial remission, not complete remission. But like with most of the new medications, it is the combination that really matters. So can we avoid chemotherapy in patients with relapsed CLL? This is one of the trials which gives us hope that yes, that may be possible. As I mentioned, bendamustine and rituximab is one of the commonly used chemoimmunotherapy. This study, what they did was, they compared patients who received that combination, bendamustine rituximab, with combination of this drug, venetoclax and rituximab. And what did they see? Well, as you can see here, if you look at the patients who are remaining without progression, this line represents patients who received the new drug, venetoclax and rituximab, compared to patients who received a standard chemotherapy. Again, showing that combination of new agents are making significant impact on the outcome of these patients. So the message is venetoclax rituximab combination leads to better disease control compared to bendamustine rituximab. So with that, the points I want to make is, one, significant improvements are made in the past year and the past few years in not only the management but also understanding of the disease, identifying the high-risk patients, and identifying appropriate treatment options. Second, importance of personalized therapy. As Dr. Iram Khan mentioned, it's not one size fits all. That applies to most of the blood cancers now, because you need to know the patient characteristics and the disease characteristics before you say which is the best drug for a particular patient. And finally, non-chemotherapy options, as you see, is becoming more and more popular in first-line and subsequent therapies in CLL. And of course, I encourage every one of you to participate in clinical trials, because that is the way we have made all this progress. Thank you very much.
Thank you.